Can we start?
Yes, we can start.
Hello, everyone. Good evening and welcome to this meeting of headache subsection of Indian Academy of Neurology. As a chair of this subsection, I invite you all for this interesting series of clinical cases in headache. And I hope that this series will become popular as the time goes by, and we will have a lot of participation, especially from our younger colleagues, so that we can actually solve a lot of headache problems in our day-to-day practice. Also, I would like to take this opportunity to request you to kindly put up your suggestions to me or to Dr. Ashish Duggal for what are the other things you want to do for you from the headache subsection point of view to further the cause of headache subsection. Obviously, during the annual conferences, we'll have our presence in the form of symposia and in terms of the definitive slots being given to headache medicine, but otherwise, throughout the year, how we can activate and make it more engaging and more interesting for all our neurology colleagues. So with these opening remarks, I invite you all. So we have our first talk, an interesting case to be presented by Dr. Thomas Matthew. Now, you all know Dr. Thomas Matthew. He is in St. John's Medical College, Bangalore. He is a professor and head there. And he is a very good orator. And he has got special interest in headache, MS, and also some interest in stroke. So, and he has published a lot of papers on headache medicine. And his special interest, of course, is medication overuse headache due to oils, essential oils. So I invite Dr. Thomas Matthew to start his presentation. Dr. Matthew, please.
Thank you, Debashri sir. Thank you for inviting me to give this talk. And I'm always obliged to IIN for always inviting us to share our experiences in the field of headache. And today, there is nothing with respect to essential oils. So it is something totally different. So sir will shout at me if I present anything on essential oil because he's fed up of my essential oil talk. So I'll talk something totally different.
No, you are an international celebrity now on essential oils. So you should now move on to some other.
Yes, sir. Okay. So we will start with this case, and it's a very interesting case. I'll tell you the story. 1 second. Oh, my slide is visible, and let me see it's moving also. Okay, see, venous thrombosis and idiopathic intracranial hypotension, the chicken or the egg. So I'll tell what all these things means. So it's a very simple case, a 28-year-old lady. The whole family is my patient. So this lady came, is married to one of the sons who is my patient and friend. So she came with headache and vomiting of 3 days duration, which was diffuse and severe. There was no history of any fever or any trauma to the head, no ear discharge or any other predisposing conditions. There was no history of hypertension, no past history of any headaches or migraine in the past. He was using oral contraceptive pills for 1 month for menorrhagia. So with headache and on a background of use of oral contraceptive pills, a possibility of venous thrombosis was thought of. And examination showed early papilledema. There was no deficits. There was no neck stiffness. So an MRI brain with an MR venogram was asked for. And as clinically suspected, there was a left frontal hemorrhagic infarct. And you can see the sinuses, superior sagittal sinuses, the flow voids are not there. It is getting thrombosed, and you can see the susceptibility weighted images showing the dark sinuses with the veins suggestive of a venous thrombosis. Sir, the slides are moving, no, sir?
Yes, sir.
Yes,
Slides
yes,
are moving,
yes.
right?
Yes, yes.
Okay.
Carry on, please.
Yeah. And the MR venogram showed an absent superior sagittal sinus, and the right transverse sinus were absent. So the diagnosis of venous thrombosis was confirmed. So the MRI showed there is a superior sagittal sinus and right transverse sinus thrombosis with a left high frontal bleed. So she is, if you go by criteria, it's a headache attributed to cerebral venous sinus thrombosis. 6.6.1 is a diagnosis. She was started on low molecular weight heparin and also anti-epileptic medicines. And then she was given anti-edema measures. And then, so this was happened when I was not there. I think she came to the emergency and then all these things happened. So I came to see them on the third day after the admission. And when I came there, she told my headache is persisting. And then, but she told that my headache, though it is persisting, there is no headache on lying down. She told headache appears only on sitting or standing. Then I clarified the history. I asked them whether when you came, you had headache which was postural. She told, no, I came with a continuous headache. After treatment, there is little improvement in that headache. But now I have another headache which comes up on sitting or standing. And when I'm lying down, I'm fine. So there was a postural headache, an additional, which came on the third day of admission after being treated for venous sinus thrombosis. And there was no history of any lumbar puncture done for the patient. So she fits to a proposed diagnostic criteria for spontaneous intracranial hypertension. This is by Shibing et al. She has orthostatic headache. She has this opening pressure we have not done. We have not done any improvement in patching. The demonstration of an active cerebrospinal fluid leak, a cranial MRI appears suggestive SI. So this is the criteria. So we'll see that now the MRI spine is done in the next slide. There is no reason non-dural puncture. Symptoms cannot be attributed to another disorder. So I'll show the MRI there. I think I missed the slide. I'll show that MRI which shows the spinal leak. So she fits to a headache which is attributed to low cerebral spinal fluid pressure and in an intracranial hypotension. So she had a headache attributed to low pressure, and the MRI of the spine showed the leak. If you carefully see, there is a little collection in the cervical spine anteriorly and also in the dorsal spine posteriorly. You can see that the dura is pushed forwards, and there is a collection around the spinal cord, both anteriorly in the cervical spine and posteriorly in the dorsal spine. And also you can see in the lower images, there is a collection anteriorly and posteriorly, and the dura is pushed. And if you see the other axial images, you can see again this collection in the epidural area in both posterior, and here you can see in the anterior part of the spinal cord. So MRI showed spinal epidural leak. And again, if you go back to the criteria, you can see that the criteria says that there should be an orthostatic headache, and among one of the following, if you have an MRI of the spine which demonstrate a spinal epidural leak, it can be suggestive of CSF leak. So this is so how did we manage this patient? This patient, we continued CVT management, continued the enoxaparin, give absolute bed rest for around 2 weeks. Because she's on anticoagulation, we cannot do any epidural patch or anything like that. And most probable reason, we thought that patient had a venous thrombosis and she had vomiting. And maybe because of this vomiting, there happened a dural leak. She had no features of any Marfan syndrome or Ehlers-Danlos syndrome. And then this is after 3 months of follow-up. Patient improved well. We got discharged, and the repeat scan shows the resolution of the edema in the left frontal lobe, recanalization of the sinuses. And also you can see the pressure on the dura has gone down, and the dura has come back, especially in the dorsal region. You can see the dura has come back, and the normal CSF has come up everywhere, and you don't see that epidural leak, and she improved fully. So the diagnosis, the complete diagnosis, she had a cerebral venous thrombosis, that is an headache attributed to cerebral venous sinus thrombosis, plus an intracranial hypotension, that is 7.2, headache attributed to the low cerebrospinal fluid pressure. So here is a case which is very rare. We have seen a lot of venous thrombosis patients. Rarely we have any case of venous thrombosis with an idiopathic intracranial hypertension. So it is one of the rare cases where a venous thrombosis has happened and then you had an IIH. And the only clue for this is the headache. We clarified again and again with the patient. When it came, she told she's a continuous headache. We admitted, we started treatment, she felt better. But at some time, there happened this in the third day or fourth day, there happened a postural component to the headache, and which was worsening on sitting and standing, but not in the lying down posture. So if you search the literature, you don't see anything about CVT and IIH. You see IIH going on to venous thrombosis. That's what the literature tells. So there are many case reports. Not too much, but there are case reports. This is a case report which came in the American Journal of Neuroradiology, where venous sinus thrombosis in spontaneous intracranial hypertension. And there are other articles like this, which was presented in the Shibing et al., where he has proposed the criteria: cerebral venous thrombosis in spontaneous intracranial hypertension. So a potentially life-threatening complication of intracranial hypertension is dural venous sinus thrombosis. It occurs in approximately 2% of patients with intracranial hypertension. So you all know the Monro-Killy hypothesis, which states that the sum of the volume of intracranial blood, CSF, and the brain remains constant. So here, because of a leak and there is a decreased CSF volume, which occurs in spontaneous intracranial hypertension, there occurs a dilatation of the intracranial veins and increase in venous volume, because the brain itself cannot change significantly. So basically, it is either the CSF volume or the blood volume. So there occurs a dilatation of the intracranial veins and increase in venous volume. And the area of the dural sinuses increases almost by 70% in idiopathic intracranial hypertension. So you know that one of the earliest signs of idiopathic intracranial hypertension is engorgement of the veins. And this increase in diameter reduces the velocity of the blood flow. And this has been demonstrated in straight sinus even after lumbar puncture. So there occurs a venous stasis because of this dilatation. And this slowing of the blood flow is one of the causes which is thought to be predisposing to clot formation. And also, because the CSF is draining out to the epidural space and is not going to the venous sinuses, there is an increase in blood viscosity due to reduced absorption of the CSF in the cerebral venous blood, which also contributes to this prothrombotic effect. And also, because of the sagging of the brain, it pulls on the venous structures, and distortion of the venous structures due to the downward displacement of the brain also contribute to increased risk of thrombosis. So in short, when occurs a dural tear, there occurs an intracranial hypertension.
Thomas, we can't hear you. Ashmita, what happened?
Sir, there is a network connectivity in Sir's side. I guess Sir's network is fluctuating.
Okay, please wait, ladies and gentlemen.
So the main...
Yeah, he is there. Yeah, Thomas, carry on, please. So, Thomas, you are muted, I think.
So till what side do you have heard, sir?
When you were showing the flow diagram for pathophysiology.
Okay, 1 minute. I'll go back. Something happening here.
Probably your connection is unstable.
Okay, maybe because of that. Let me go. Yeah. So this I think you heard, right?
No, but it is not showing on the screen now. Please stop screen share and do screen share again.
Okay, 1 second, sir. I have to do the escape. I'm stuck here.
And for the participants, for all the people who have joined in, please put your questions answer either in the chat or the question answer box. We'll respond to that.
So 1 second.
Discussion. That's very important.
So click on shares.
1 minute. Mansi, you called me in between for anything?
No, sir. It's okay. The issue is solved.
Kindly share it again and
yeah, I'm doing. Has it come?
Yes, sir.
Yes.
1 minute. Let us put in the view show. Sometimes it doesn't move after that. Now?
Not yet, sir.
No.
Is it moving? No. 1 second. New share. New share. Share.
Yeah. Now it's moving.
Has it come?
Yes.
Yeah, yeah.
It's moving now. That's fine. So I think we reached here. A dural tear causes intracranial hypertension, which may lead to subdural collection. It can also cause a slow flow in the cortical veins, and then venous sinus thrombosis, and then hemorrhagic infarct and seizures and things like that. This is a case from literature which shows you can see an old subdural effusion, which is not acute, but now the person has come with a worsening of the pattern of headache. Now you can see here, usual feature is you have a postural headache to start with, and then you get a continuous headache or you get a seizure. So a classical case of IH, when they get a change in pattern of the headache or get some complication like seizure, then you do a repeat scan. You see the venous sinus thrombosis, the cord sign, and then you can see a vein, the cortical vein thrombus, again hyperdense on CT, and then this hemorrhagic infarct. So bleed in the left frontal region. So this is how the IIH goes on to the CVT, and the key pathophysiological mechanisms, as we have discussed, it can be venous stasis, CSF depletion leading to increased blood viscosity, and vascular distortion secondary to brain sagging. So this will cause all the components which are needed to cause a clot in the brain. So this is one of the largest case series, again by Sheving, and it tells almost 141 patients of spontaneous intracranial hypertension in a case series. Only 3 were diagnosed with cerebral venous sinus thrombosis. So it's a very rare complication, around 2.1% in the series. And there are 17 reported in the literature altogether. And along with these 3, so around 20 people, total has around 11 men and 9 women with a mean age of 39.5 years. And radiographic or clinical evidence of spontaneous intracranial hypertension preceding CVT was found in most patients. There was no evidence for CVT preceding spontaneous intracranial hypertension in any patient. That is where our patient is rare, because here it was a clear-cut oral contraceptive pill. She had headache, which was continuous in the beginning. Started treatment, there was a change in pattern, and when we did the MRI spine, there was a spinal epidural leak, and we think that the vomiting, which would have caused a tear in the dura and would have caused the additional component of IH. Here the CVT went with after that IH. In the case series, what is reported, there was no evidence of CVT preceding spontaneous intracranial hypertension in any of the patients. And 8 out of the 20 patients, that's around 40%, which is reported in the literature, were found to have a change in their headache pattern due to the development of CVT. But we should understand that it is not present in majority of the patients. And the complication of CVT, like venous infarction, occurred in around 40%. That means the parenchymal involvement was seen only around 40%. Others are a pure sinus thrombosis. Spontaneous or secondary postural headache, which loses its postural component and worsens, should raise the suspicion of an intracranial complication like cerebral sinovenous thrombosis or cortical venous thrombosis. And once the CVT is confirmed, the priority should be given to its treatment. The CVT takes priority over the management of IIH. So give full anticoagulation, give complete bed rest, and don't do any intrathecal injection on anticoagulation. So that is one learning point. You treat the CVT. So there occurs an interesting two-way relationship with CVT and IH. And IH can lead to CVT, or sometimes CVT leads to IH. So in our case, we think it is clear, but there are no reports on CVT and IH. So I'd like to discuss with Dr. Debashish and Ashish and all whether they have seen any phenomena like this. So sometimes if the history is not clear, we don't know the chicken or the egg which came first. So that may create a problem. So there is a dual relationship between CVT and IH, and maybe the beginning of the history may be important. Thank you. Thank you for your kind listening.
Thank you. Thank you for a very nice case. And I think it is very, very pertinent case, because now this has been talked about. And as you said, now the figures are in the range of about 2% the association of SIH with CVT. But then there are questions which you need to answer. Dr. Girish is asking, any contrast MRI done, or whether any direct MRI brain features of SIH in your case?
Yeah, I think we did repeat MRI, and this one, I think there was no classical features of, IH. I didn't have to put that MRIs. So I think there was no major sagging or anything we could not see. I think it was only the leak, and we picked up pretty early. So I think by the third day, fourth day, we have picked it up. I think it has not gone to too much of any complications.
Right. So then there is very interesting question. I think, Thomas, you should take it up. Can ongoing CSF leak be diagnosed radiologically?
Absolutely. I think if the CSF leak is ongoing, spinal, I think you are speaking about the spinal CSF leak. There are, I think the MRI is good enough to pick up. A good radiologist should be there, because you should differentiate from the epidural fat and the the subarachnoid space. So you should have a good radiologist to pick up this leak, because people may miss it as normal. You have to carefully check for the dura, and you can see that the dura is pushed forwards, and then you can see the collection. So you have to check, carefully search for the dura. And if the CSF leak is prolonged, of course, you get all the signs of the IIH, engorgement of the veins, sagging of the brain, diffuse enhancement, pituitary enhancement, the pons getting flattened. So it's a lot of signs.
No. So he's asking that if there is an ongoing dural tear and the leak, can you find it out? That is so. Your answer is partially correct. I think that normally if you do just an MRI, you may miss it.
Yes.
Until and unless you have to do a heavily weighted T2 image of the spine, right? See, MRI spine with a heavily weighted T2 image. This is a special technique. You should ask your radiologist to do that, and then you can see the the leakage along the sleeves of the dura. So that is the standard. Of course, if you don't consider so much about the kind of recommendations or protocols, then people have done that. They have injected gadolinium and did a MR Milo, and then they have demonstrated the leak. But as such, it is not recommended to inject gadolinium in the CSF space. So that is not approved, but people have done it. But the best method is to do a heavily weighted T2 image of the spine to see the leak. So that possibly answers your question. Another question to you is that, and a couple of people have asked this, that could you identify the site of this leak in this patient?
Yeah. So what happens is that there is no need to really chase for the site in the initial part. When you first evaluate, like Sir has correctly told, you may do a CT myelography or an MRI myelography, and you may demonstrate the leak, but it may not be needed in the usual cases, because if you are going for a bed rest, or you can go a blind epidural patch, you may do. And then if it is not improving, then you may find the leak, and then you go into the exact site. You can go radiologically guided, you can go and seal the leak. But usually you may not need to do that in the first go if the patient is better with a blind patch. But in this case of venous thrombosis with the CSF leak, or an IIH complicating this, when venous thrombosis comes, because you are anticoagulating, you should not do any epidural patch. I think you should just give bed rest, and usually they will come out of it.
I think in your case, since there were some, already there's an existing problem, and you cannot obviously do an epidural patch in this. It might not be, but otherwise it is, you should make all the effort to locate the leak, because, then your blood patch will become successful. See, and you may not get success with only first blood patch injection. You may have to repeat it. So the data says that your actual efficacy increases by about third or fourth blood patch. So it is very important to locate the leak. But if you can't, but it is not mandatory to diagnose SIH until and unless you have demonstrated the leak. Somebody asked that question. It is not mandatory, but it is always preferable to locate the leak to have a proper blood patch location, right? And second is this, that Dr. Parthare is asking that your patient seems to have a cervical as well as a lumbar leak, two sides.
Yes.
Please clarify.
Yeah, there was an extensive leak. The leak was there in the cervical as well as dorsal and lumbar, the extensive leak around. But she didn't have any complication, just bed rest. She improved with the CVT treatment. And indeed, we stopped the venous anti-edema measures, I think, because there was a postural component. We stopped the anti-edema measures. We just gave anticoagulation. Initially, we gave Clexane, and then we gave dabigatran, and then we just continued levetiracetam because of the bleed. We didn't do any anti-edema measures because of the IIH was superadded with that. And with that, with bed rest, she improved. We didn't need to go for anything else.
Correct. So I think there is always some degree of, I think, uncertainty. I think Thomas is a good case you collect. And I have heard one such case in one of our meetings in Mumbai. I think somebody had presented in one of our meetings. So I think we need, from India, we should collect. We have, I think, 2 cases now of this kind of situation where there has been a coexistence of CVT and SIH. So I think if we can totally from India, we can collect and somebody takes the pains of writing that up, then we could have a large series and then we can publish and it should
I'll do
go
it,
from
sir.
India.
I'll do it.
Right. So I think then we will proceed with the a treatment part. Of course, bed rest, caffeine, coffee, and all these things are, initially tried. Many people do respond, at least partially initially, but most of the people will get better with the epidural patch. So there are a lot of issues with SIH, and I think our time is not going to permit that to have a full discussion. But it's a very interesting case, and I think a message should go to all the people that whenever you find a case of SIH, you should look for other things also. It's just not an SIH, but there might be other things as well. So I think we should go for the next case, which is by Dr. Sanjeev Bhoy from AIIMS Bhubaneswar. Dr. Bhoy, please.
Respected sir, am I audible?
Yes.
Yeah,
sir.
you are audible. Can you, Thomas, can you stop sharing your screen so that Sanjeev can share his screen?
No, I've stopped sharing.
Okay, right.
Yes, sir.
Sanjeev, can you share your screen, please?
Yes, sir. 1 second. Sir, is it visible? Slides are running?
Yes, you put it in the slide mode.
Sir, is it in the slide mode, sir? Is it okay, sir?
No, yeah.
Oh, sir, it is in editing mode.
Okay.
Sanjeev, on the top screen now, you see again one new share. You type on that.
Okay. Yes, sir.
You put it on the new share and then again go and select it.
Okay,
put it
sir.
in the view screen and go up and there is a new share. Go there.
Now it's okay, sir.
No.
No, just wait. You open the PowerPoint, put it in the view share, this slideshow, and then go to the screen on the top. There will be a new share.
Yes, sir.
And try that.
Yes.
Yeah, now it's fine. Good.
So, Dr. Sanjeev, you can proceed.
Now it's running, sir. Slides are running.
Yes, yes.
Yes, sir. Thank you, sir. Respected sir, and at the outset, I will thank sir for giving me the opportunity. So today we'll discuss a case of headache in a patient of lower GI bleed. Usually these patients do not come to us directly to the neurologist. However, the causes of lower GI bleed in a neurological patient are due to usually antiplatelet induced upper GI bleed, or they may harboring some GI pathology, lower GI pathology. So in this session, we'll discuss a case. He is a 35-year gentleman, daily laborer. He presented to us with bloody diarrhea from last 2 years. But that was not the presentation to the neurology. Sir, am I audible?
Yes, yes.
Yes.
You are audible.
Thank you, sir. So he came to us because of the headache, that is 1 month duration. He landed up in the emergency department of AIIMS Bhubaneswar with 1 day history. So he has a history of weakness of left upper limb and lower limb from last 3 days, vomiting 2 episodes before coming to the emergency department. And he has multiple episodes of seizure involving the left upper and lower limb. So this gentleman was having a chronic illness of lower GI pathology with a recent onset headache, and the emergency arrival is due to the left-sided weakness with seizure. So coming to the history for the resident, he was apparently well for 2 years back. He developed loose motion. So what was the character of the loose motion? So the gastroenterology they described, it is 3 to 4 times per day. The amount of stool was very small, containing blood and mucus. So it was not like a rice water like diarrhea. It was a small amount containing blood and mucus. It was non-foul smelling, and there is no relationship of the loose motion with the food intake. Pain in abdomen was there, and sensation of incomplete evacuation was present in this patient. So there is tenesmus is there. So from last 1 month, he has a low-grade headache. So what was the character of headache? It was a holocranial headache, continuous, diagonal, and there is a positional variation was there, aggravated by coughing and sneezing, and relieved by analgesic. So this headache is not classical of a primary headache. So this was a classical of a secondary headache, that is change in posture, diagonal variation, and with pressure that increases. So there was transient visual obscuration suggestive of clinically a papilledema. There is no history of photophobia, phonophobia, nausea, and there was occasional vomiting from last 3 days. 3 days back, when he got up at night for bathroom, he started dragging up the left upper limb. He has to lift the leg with his hand, supporting the left leg, the weak leg. Next morning, he noticed that he was not able to move his left upper limb and lower limb. So initial night, he developed the left lower limb weakness. Next morning, that weakness has progressed to involve the same side upper limb. So with that weakness, there was a seizure-like episode, it was a focal onset seizure, motor seizure, involving the left upper limb, the weakness side, upper limb and lower limb, with secondary generalization, and there were ultrasensorium for 2 minutes. So followed by loss of consciousness and total awareness regained after 1 hour. There was no involuntary urination and tongue bite. So this patient has weakness, and he developed a classical motor seizure involvement of the weaker side. While shifting the patient to the hospital, he also has 2 episodes of vomiting, which is moderate in amount, irrespective of food intake, projectile, non-bilious. Attendant also noticed that patient is not responding to family member. So gradually the sensorium also deteriorated in this patient. There was no past history of fever, dysarthria, dysphagia, diplopia, small joint pain, skin discoloration, chest pain, palpitation, cough, hemoptysis, weight loss, loss of appetite, leg swelling, or dyspnea. So coming to the past history, he is a non-diabetic, non-hypertensive 35-year gentleman. No addiction, average body build, mixed Indian diet. So there is no family history of similar illness. So he was given multiple antibiotics by the local physician before coming to here. And he was on probiotic BD intermittently. So coming to the structure involved, he is having a primary illness in the past, the GI mucosa in form of diarrhea containing blood and mucus. The right internal capsular lesion, anatomical site for the left hemiplegia, because it was a dense hemiplegia initially with sensorium was intact. But later on, he developed the raised ICP, suddenly within a span of 6 to 8 hours, that is in form of headache and ultrasensorium and blurring of vision, obscuration, suggestive of raised intracranial pressure, cerebral gray matter involvement because of the seizure disorder. So coming to the provisional etiological diagnosis, we will put because of the GI pathology from last 2 years. So it may be a case of inflammatory bowel disease because of the blood and mucus and tenesmus. With that, the neurological symptoms may be either a CNS vasculitis or a cerebral venous sinus thrombosis. Let's see what happens to this patient. On examination, the patient was in altered sensorium. He was afebrile. The pulse was slightly in the lower side, 62 per minute regular. The BP was in the higher side, 170 by 90, equal on both the sides. Respiration was quite stable. He was having pallor. So pallor was highlighted here. We'll discuss later on why the pallor is important. There is no icterus, cyanosis, edema, lymphadenopathy, thyromegaly, and other systems were examined. The abdomen was also soft, non-tender. So the GCS was E2, V1, M5 around 8 by 15. So low GCS. The pupils were normal size and reaction. Fundus was showing papilledema and left EM and facial weakness. So he came to our emergency on day 3 of the left side hemiplegia. Motor-wise, he was having left side hemiparesis, hemiplegia around 3 by 5. There was hypotonia and the extensor plantar bilaterally. And he was able to perceive deep pain. There is no meningeal signs. So this was the initial emergency X-ray. So we got the X-ray of the chest only because of the routine procedure. But I have demonstrating what is there in the X-ray. I could get the lower part of the abdomen, the upper part, where you can see there is some dilatation of the colon is there. So when we see meticulously, this part, the arrow showing is the dilated, the transverse colon in this patient. So coming to the CT head, the initial investigation, it's showing a lesion, hyperdense lesion in the right frontal, the polar area. There is extensive edema, so that is a hemorrhagic infarct-like, but that is not restricted to the only one side. It is coming to the other side also. The left side, there is also a hemorrhagic lesion with edema. So a patient having bilateral lesion, hemorrhagic lesions, always think of some venous obstruction. So coming to the MR image, the upper panel T2 diffusion, flare and ADC, the same finding we are getting a heterogeneous hyperintense lesion with a surrounding hyperintensity, the edema, and diffusion, there is very minor diffusion restriction or there is no diffusion apparent restriction, and the flare image is showing same as the T2. And the upper cuts, when you go, there is a area of restricted diffusion with slight ADC reversal is there, and there is extensive edema bilaterally. So coming to the topmost cuts, we are getting bilateral lesions with edema. So this was the MRI finding, and the conventional T1 weighted image showing area of hypodensity. So we cannot see the flow birds in the classical because this is not showing the higher cuts. Wherever the posterior part of the venous sinuses, it's showing slightly apparent there is loss of flow in the sagittal sinus. Coming to the SWI or the GRE sequence, where you can see the blooming of the lesion. So they are all hemorrhagic lesions with slight diffusion restriction. So they are suggestive of a venous infarct. So coming to the MRV, this is the contrast MR venogram in this patient. The sagittal view is showing that the anterior 1/3, the middle 1/3 of the superior sagittal sinus is not visualized, whereas the posterior 1/3, the transverse sinuses and the straight sinus and slightly blurring of the internal cerebral brain. So as there was motion artifact in this patient and it was in a critical condition, the proper MRI we could not do. So with this motion artifact image showing that the anterior 2/3 of the sagittal sinus is not visualized and the rest is okay. And you can see here there is dominance of the right transverse sinus and there is no dominance on the left transverse sinus. The MR angio is quite okay. The coarse caliber and the branching patterns are okay. So coming the zoom image, you can see the anterior 2/3 or whole of the sagittal sinus, only the lower part is visualized, whereas the transverse sinus both are visualized. The straight sinus and the internal cerebral brains are also there. So the deep systems are okay. On the superficial sinuses the superficial sinus is the area of interest that is pathological. Coming to the blood investigation, as said in the clinically there is anemia. The hemoglobin was 10.4 gram. The MCV 88 normal. The TLC count, retic counts, liver function, ESR, iron are all apparently normal. Coming to the other investigation, the triple serology, HIV and other viral markers were negative. Urine, ECG, 2D echo, thyroid lipid profiles were normal. So coming to the hospital course, how to deal with this patient with a past history of GI bleed, tenesmus, bloody mucus, coming with a left side hemiplegia, seizure, MRI showing features of venous sinus thrombosis, involvement of the large sinus with the superior sagittal sinus. So provisionally diagnosis of CVST with inflammatory bowel disease. The patient received unfractionated heparin. So the standard dose of unfractionated is 1000 intentional units per hour either through infusion. But here we are not sure because the patient was in active GI pathology. He was still having the GI, blood and mucus diarrhea. So he could not go with a full dose. So we started because 500 we can titrate gradually in the ICU. So we have opted for the unfractionated, not the LMWH, because you cannot revert also. Here in the unfractionated, you can stop and within 1 hour that can revert. So we started with a low dose 500 intentional unit IV infusion and tablet. Later on, a tablet acetone was added. He was given initially with mannitol and the seizure control was levetiracetam. So when we try to increase the unfractionated heparin to 1000 intentional units per hour, that is total dose of 24,000 per day, the patient started having slight increase in the bloody diarrhea. So we could titrate between 500 to 1000. On day 3 of admission, the patient has anisocoria. Now the real story started. He was having anisocoria and GCS worsen because the part of that sinuses was not opening up. He was having E2, V1, M5. The initial GCS became E1, V1, M2. So drop in at least 3 points in the GCS. The repeat head swing, subfalcine brain herniation. Then patient was intubated and there was plan for a right frontoparietal decompressive craniotomy. So was subjected for the surgical intervention. So this was the hospital second CT image when he developed the subfalcine herniation. You can see the edema. Sir, am I audible?
Yes, you are audible.
Yes, sir.
Continue.
Thank you, sir. So with the repeat scan on day 3 with the sign symptoms of herniation, the CT also showing same feature, the subfalcine herniation. And this was the patient in the ICU when he was intubated and he was planned for a decompressive craniotomy. The decompressive craniotomy was done on the right side. We do not do the diversion of the CSF because immediately they were taken for the decompressive because the patient was herniating. So this was the after the decompressive craniotomy, it was quite open up. The midline shift was slightly restored after the decompressive craniotomy, and there is bulging of the brain tissue. So how the hospital course? The patient syndrome improved over the next 2 weeks. Tracheostomy was done, and he was obeying command. Then GCS improved from around 8 to now 10 with a tracheostomy tube. Now we started for evaluating what was the cause of the diarrhea, because initially we have to manage the CVST with a herniation and patient going to a low GCS. So we could not go for a full colonoscopy initially because of the patient on ventilator, heparinized. So we go for a partial, that is proctosegmentoscopy with biopsy of the lower GI mucosa. And the biopsy was suggestive of ulcerative colitis. So with the gastro colleague, we started mesalamine enema, that is the standard of care, followed by mesalamine. They have advised for 1.2 gram OD for 4 weeks. On discharge after staying for around 1 month, he was on E4 VTM6 on tracheostomy tube in situ. The power was same 0.5 left upper limb and lower limb, but he was responding and he was conscious. So this was the proctosigmoidoscopy induced, the process induced biopsy of the lower part. It's showing chronic ulcerative proctitis with focal activity. So we could not go higher up to the colon. So this is a representational image from the journal where you can see in the X-ray also, the earlier days they can see that multiple air fluid level in case of classical ulcerative colitis, and there is loss of hustration in the transverse colon, the upper panel, the arrow, and there is some foci of CT density or the X-ray density is there. There are we can get the pseudopolyp with calcification, but the pseudopolyp is classically seen with the CT image. Here you can see the ascending colon, the right side arrow, the middle portion, upper one. There is dilatation of the colon, and there is air fluid in the wall of the colon. The same thing here, the dilatation of the sigmoid colon, and here the descending and the ascending colon, the right side panel. So this is a classical image. In this patient, we could not go for a CT abdomen at that time because of the critical condition. So on the retrospectively, we have seen the X-ray where the chest X-ray was done and could get some upper portion of the transverse colon. You can see that there is smoothing and the dilatation of the transverse colon only. And follow up, the patient, the story didn't end. He improved power, left upper limb and lower limb. The part of the bone flap that was kept in the left part of the intra-abdominal wall, and the tracheostomy was closed within next 2 months. But he had non-healing ulcer in the left abdomen where the bone was kept. So he was again roaming around to the surgeon and everybody how to deal with this non-healing ulcer. He was readmitted ultimately to our side again. So this was the bone flap. The initial photo he have sent from his house, because the gapping of the wound was there and the white area, the bone area was showing some infection. So with the neurosurgeon, ultimately we could remove the bone flap, the infected bone flap that was kept for a repositioning later on, and the wound was really healed. So this was the pre-admission before the onset of illness. This was the photograph. This was during the ICU stay and during the follow-up when we could close the tracheostomy and the bone flap. So later on, the patient was again, colonoscopy was planned when the patient was stable. And the colonoscopy this time done because after 4 weeks of that mesalamine treatment, the patient has stopped the treatment. So again, he developed the blood mucus diarrhea. So we reassured that it should continue for more time, at least 6 months to 1 year. And the colonoscopy was again, full colonoscopy was done showing a pancolitis. This was the last picture around 1 week before the patient was discharged. And the weakness, now he's able to walk. So coming to the briefly in few slides, what is ulcerative colitis and CVST? Whether these are entities known? Yes, from the MBBS day, we know that ulcerative colitis, the extrahepatic GI manifestations they are having the more procoagulant state. So CVST and inflammatory bowel disease till date, till 2021, 35 cases are reported. In the IBD, that is the inflammatory bowel disease that constitute both UC, the ulcerative colitis, and the Crohn's disease. However, the ulcerative colitis have preponderance more for the venous sinus thrombosis or the deep vein thrombosis in the peripheral area or the lung thrombosis, pulmonary vein. But Crohn's disease, only hardly you can see the only 6 to 7 cases are there. But in ulcerative colitis, total till date 27 cases are reported. The incidence of overall venous thrombosis, both peripheral and the cerebral, is 1 to 7% in IBD. This is not for the CVST. The duration of IBD and CVST is 3 years, from 2 days to 16 years. So that we should not say that the patient will not develop after a prolonged time. They can develop after 16 years of IBD. They can develop the venous sinus thrombosis. So the incidence of venous sinus thrombosis is more in case of ulcerative colitis. There is a large review of all cases in the 2021. That's it, 35 cases. Out of this, 3.8:1 ratio of ulcerative colitis is to the Crohn's disease. Young male are more affected, and the IBD should be active at the time of venous sinus thrombosis. So 92% they have active GI bleed. The headache is the most common symptoms of ulcerative colitis with CVST. Multiple sinuses are involved in 65%, and the superior sagittal sinus is the most common sinus, that is 71%. Other thing is that who will develop a CVST? So the literature says the patient who are IBD patient who are on steroid, that is most commonly associated with CVST, and anemia second most common. So a patient of IBD, if he is having active bleed, male, young, on steroid therapy and anemia with headache, suspect CVST. Complete recovery is 77%. Bleeding complication is very rare, so don't worry about the bleeding, only less than 10%. One case, there was increased ICP and that required a VP shunt in the literature only. So they could not open at the time, they only done the VP shunt. So the pathogenesis is again same like CVST. There is thrombogenesis, prothrombotic state increases. Second is the steroids sometimes inhibit the prostacyclin-induced vasodilation, that produce more atherothrombosis, and there will be more clotting of the veins. Coming to management, the standard is of CVST is same, heparin or low molecular weight heparin, followed by oral anticoagulation. Out of this all 35 cases, there is only 2 deaths. One is raised intracranial pressure and another was a bowel perforation. So coming to the conclusion, suspect CVST in patient with IBD with headache and raised ICP if the patient is having steroid and the patient is having anemia. Management is challenging, multidisciplinary. Heparin and oral coagulation, anticoagulation, 6 to 12 months. Even if the standard dose is 3 to 6 months, but here you have to give slightly more. Hematotagia, monitor INR closely, don't stop the anticoagulation. Major bleeding with therapeutic anticoagulation is very less likely, so you can go with the treatment. So an outcome is better in this type of patient. Thank you. Thank you, sir.
Thank you, Sanjeev, for a very nice case and well worked up case. Thank you very much. There are a few questions for you. Obviously, the diagnosis is not such a suspect in your case. I mean, obviously, we know that there is an association between inflammatory bowel disease, especially the ulcerative colitis and CVT. But I think the real problem is the management. Because when the patient is actively bleeding, then the question comes that how should we anticoagulate and what do you do? So there are 2 questions for you. One question at least, that what anticoagulation did you give on discharge? And second question is that since toxic megacolon has 80% chance of perforation and peritonitis, where gastrosurgeons involved, did you use MAP therapy for ulcerative treatment or only enema and oral misalazine? That will lead to relapse once you stop the therapy after a month.
Yes, sir. So the initial anticoagulation was unfractionated heparin during the hospital stay, and he was subjected for the decompressive craniotomy also. Later on discharge, we have given acetrom 2 mg with maintaining the INR around 2. So the patient with that, there was no headache. The features of CVST recovered. So we didn't repeat as MRI now. We'll repeat in the next month. The patient is still now around 3 months now. So the second question is the toxic megacolon. Yes, in the ulcerative colitis, they develop toxic megacolon. But in this patient, the GI gastroenterologist, they have done the digital examination that they could not find the dilatation of the lower GI path. And they thought it's only the proctospheric sigmoid also didn't show any dilatation, large dilatation of the sigmoid colon. So we have given the enema, the mesalazine enema, and the oral therapy. So 2.4 gram BD, that is 4.8 gram. And they continued for 4 weeks. That was our problem. So the patient stopped the medication after 1 month, develop again the GI symptoms. So the thing is that we should not stop that treatment for the GI, the ulcerative colitis. That should be continued for at least 6 to 12 months. After readmission, the patient now is asymptomatic, sir.
Okay, I think a lot of counseling needs to go into it. Okay, ladies and gentlemen, I am very pleased to announce that our President, Dr. Nirmal Surya, is now with us. And since this is the first program webinar of the headache subsection, so I just request Dr. Nirmal Surya to say a few words to all our colleagues and for the headache subsection as such. Dr. Surya.
Thank you, Devasis and Ashish Dugal. It is indeed a great initiation by you guys to start the headache subsection meeting, which is going to happen every 2 months, if I'm correct. And of course, I was yesterday, day before yesterday, I was in the conference of Arch, which was attended by nearly 1,200 people, and I was talking to Tisha and Ravi. There's a lot of interest has been grown in the headache, and I'm sure these sort of a case discussion and deliberation. The first case was fantastic by Thomas, and then now there's another case which is very, very interesting from Professor Dr. Bowie. So these will cause a lot of interaction and learning. My only suggestion to you is invite the younger people if they have some interesting cases to write to you to present.
We send an open invitation. And I again will re-emphasize today, since you are saying that please all youngsters must join and they present.
And bring the difficult cases so that expert like you all guys can highlight and help out the others. I think these are good initiation by headache subsection, initiation by the stroke subsection to do the journal every 2 months. I am sure other subsection will really take it forward and education will grow. I would be happy if younger people, students, and even other subspecialty and even the physician, if they get involved. So maybe when we send the email, we will send it to all the
Right.
physicians. If they are interested to join, they are most welcome to be part of it. Thank you once again. And very interesting and good thing is that all this will be available on our YouTube channel. So
Right.
even if somebody has missed out on the live because of his busy schedule, he can access it later in the night or whenever he has time. So thank you, Devashish, for taking this initiation. And I'm sure this will be wonderful. And I wish you all the best to both of you, to the convener and chair, to take it forward. Thank you.
Thank you, sir. And I think that's a very good suggestion that you have said, that to include even the physician and students also, so that they get initiated in neurology and headache medicine in particular. So I think that's a very good suggestion. We'll work on that. And thank you for being present. I know that you have so many meetings to attend, and despite that, you could find time, and so I'm really thankful to you. Thank you, sir. Right. So, before we proceed further, there are two leftover questions for, Thomas. So one is that people are consistently asking that, is there any possibility that she was having the low CSF pressure without much symptoms earlier, which was missed, and that led to CVT? And Dr. Ray also is saying that, what is the actual evidence that, the CVT developed prior to the SIH?
So there are two things point to that, and I clarified it because whatever I knew also was it is an hypotension going on to CVT, but in this case she was on oral contraceptive pill, comes with a continuous headache without postural variation. She takes medicine and her headache improves, but there is a persisting headache, and when you ask her how the headache is persisting, then she tells, I get only on standing and sitting in rounds on third day. So that's when we suspected a postural component to that, but it was not there in the beginning. And there was an interesting question along with that. Somebody has asked whether a raised pressure due to the venous thrombosis, the pressure goes up, it spreads to the spinal fluid down, and the dura bursts. That's a nice hypothesis. I think we didn't think like that. I thought it may be vomiting, and then we would have been a leak. But I think it's a dual relationship. I think we might be missing in patients. Most of the venous thrombosis patients, we never ask for the postural components. So maybe you should check in your venous thrombosis, and most of the time they will be bed rest and medication. So they might be improving also.
Yes, I think the possibility cannot be totally negated, but obviously since this needs to be proven by more such cases, and that's why I say that to all the members, that whenever they see, Girish said that he has already one case, so we can, collect about 10-15 cases, then it will be very nice to look at the data and, kind of analyze it and find out a possible relationship.
We have
that is
cases.
one part. Another question for you is this, that is SIH more common in women?
I think so. I think we have around 3 cases of IIH with CVT, and this is the first time CVT with IIH. And I think I'm not exactly counted, but I presume the females are more than males. That's what, if I'm thinking back, I've seen more females with IIH than males.
Okay, right. So that's very good. And now the question for Sanjeev, and that's a very pertinent question. In fact, I was thinking of asking that why didn't you consider a local, thrombolysis, sinus thrombolysis, in this case, when, giving IV or oral, anticoagulant is a risky proposition. So.
Yes, sir. We thought of a local thrombolysis, doing a borehole and do, but our radiology colleague were not available to do that thing. So, and the neurosurgeon, they said, we'll go for a decompressive directly because the patient is herniating now. So that was initially 2 days the patient herniated quickly. So before thinking of a local thrombolysis and arranging for that with the coordination with the radiology and the neurosurgeon, the patient herniated. He was in bad condition, sir. So ideally should be
Dr. Ashutosh is asking that, is there any evidence, did you find any evidence or any literature that, local mesalamine is okay, but is there, especially people who are having this, CVST, do they need some kind of immunosuppression
yes,
for their ulcerative colitis? Is there any literature for that?
Yes, sir. The incidence of The treatment is first is the mesalamine enema followed by oral mesalamine. That is quite okay. Recently, the literature they say that that is okay for the ulcerative colitis to be taken care. Second thing is the immunosuppression in case of ulcerative colitis is very dicey. So there is no literature that will say that you have to go for immunosuppression with CVST or not. And secondly, the workup for the other panel for the CVST also not required because they said that it is standard for the CVST workup. So this patient may develop a steroid-induced, OCPL-induced, but classically the prothrombotic state is same as per the same other CVST without ulcerative colitis. Sir. And immunosuppression, there is nothing, sir.
Yeah, I think that you're right. That as far as my knowledge goes, I don't think that there is a kind of a definitive recommendation for any immunosuppression there. But I think your case actually shows up that we must, collaborate with our gastro medicine colleagues and gastrosurgeons also, because
Yes,
they see a lot of inflammatory bowel disease, and I'm sure that many of these patients might be having some headaches, continuous headaches, and they might be a good suspect for even a CVT or even an IIH kind of a picture,
yes, sir.
where they can have.
Now the
It's very
incidence.
useful to analyze the headache spectrum
Yes,
in, that can be a topic of
Inflammatory.
research, headache spectrum in inflammatory bowel disease,
Yes,
and
sir.
to see that how primary headaches are and how the secondary headaches are in that group.
Yes,
I
sir.
think that's opened up new vista for that. Since I don't see any further questions for you right now, maybe that something will come up later. I now request Dr. Jyoti Sharma who is going to present the third case, and she is working as head of neurology at Fortis Noida, and she is the alumni from my institute, and she is interested in movement disorders, stroke, and headache. And she has got always some beautiful cases to present. Jyoti, please share your screen. Dr. Jyoti, can you hear me?
Good evening to all of you, teacher and mentor at
Good evening. Good evening. Please share your screen.
Unmute, Jyoti ma'am, unmute.
Good evening to all of you. At the outset, I would thank Professor Debashis Chaudhary for this opportunity, who has been my teacher and my mentor of him. So my slides are visible?
Yes. Just go down one slide. We will see that whether it's moving
Am I audible?
or not.
Yes.
Yeah, you are audible.
So I'm present.
Yeah, you are audible. Just move your slide to see. Yeah, it's moving. Go ahead, please.
Yes. Okay. All right, sir. So I'm presenting this case of 15 years old girl who was a 10th standard student, good in academics, presented in the middle of her board exams on 28th of February 2020 with history of headache of 6-day duration, which was bifrontal, severe, throbbing type associated with giddiness and nausea, occurred almost daily, relieved with NSAIDs. She also had transient visual obscuration for 1 day, lasted for a few seconds in upright posture. There was no history of motors or sensory symptoms, no history of fever, joint pain, skin rash, or drug intake. General physical examination, she was conscious and cooperative. Her weight was 70 kg and height was 168 centimeter. BMI was 24.5, upper limit of normal. Vitals were stable and rest of the general physical examination was unremarkable. On her neurological examination, higher mental functions were normal. Cranial nerves showed vision bilaterally 6/6. Fundi showed bilateral papilledema, and rest of the cranial nerves were normal. Motor system examination was normal. Sensory system examination was normal. No cerebellar sign, no meningeal sign. This is the photograph of the fundus, which is showing florid papilledema bilaterally. So this is the story of this 15 years old girl with recent onset headache and bilateral papilledema. So she was planned for MRI and contrast MR venography of brain. This was the MRI of this girl, which was showing bilateral optic nerves, which were tortuous, and peritic space, CSF spaces were enlarged. And there was flattening of the sclera and protrusion of optic nerve into the sclera. This was a coronal section. We can see the enlarged perioptic spaces. Here also we can see enlarged perioptic spaces. This was the contrast MRI, and this was MR venography, which showed hypoplastic left transverse sinus. So CBC was normal. So she was planned for LP with opening pressure since she was taking up her board exams. So LP was planned in between her two exams with the intent of making her little better by next exam. Parents were very understanding. They understood that problem, and they said that health is their priority. However, they wanted, if possible, we can avoid skipping her exam and make her better. So LP with opening pressure measurement was done, and CSF opening pressure was 38 centimeter of water. So CSF was showing no cells, normal protein, glucose, and all stains were negative. And this was the perimetry, which was showing bilateral peripheral field restrictions with enlargement of blind spot on right side. And this was the OCT of this girl. So the diagnosis was clear-cut. This was a straightforward case of IIH. So she was started on spironolactone and furosemide combination once in a day and acetazolamide 250 milligram, half tablet twice in a day, along with symptomatic treatment in the form of naproxen and domperidone twice in a day. We thought that she'll be better with this, but she got readmitted 3 days later on 5th of March with worsening headache associated with photophobia. She could take up her exam with great difficulty with the help of an assistant to write up the exam. She was very sick looking and lay down most of the time. VAS was 10 out of 10, and headache was not relieved with oral medication, and she had partial relief with parenteral medications. So now the questions were, what should we do? Should we escalate the dose of acetazolamide? Should we add steroid? Or is it fulminant IIH requiring surgical management? So I asked for repeat fundus examination, but fundus could not be done as she was unable to sit for fundus examination because of intense headache and was shifted back to room. I inquired her further with leading questions. Headache was worse in sitting position and was relieved a little bit in lying down position. And these features were suggestive of orthostatic headache, suggestive of post-dural puncture headache. So we discontinued acetazolamide and started her on combination of paracetamol and caffeine, asked her to increase the coffee intake, advised her to maintain adequate hydration. Headache remarkably reduced in intensity after this intervention, and she had complete relief over next 4 to 5 days. So we did the MRI brain, and this was her repeat MRI brain. My slides are visible. We can see this was a contrast sequence. We can see a little bit of enhancement has increased a little bit in comparison to previous one. So on follow-up, she had no headache, no visual symptoms, did not require any effective first-line treatment of IIH. We asked her to repeat perimetry, but once patients they get better, they don't listen to the treating doctors. So LP with CSF drainage is used to quickly relieve pressure on optic nerve, and occurrence of intracranial hypotension after LP in IIH patients seems paradoxical. Now the question is, like this shift of pendulum from IIH to PDPH was a bit confusing at first, but we picked it up. Now the question is, does post-dural puncture headache exist in IIH? So this paper particularly addresses this question: does post-dural puncture headache exist in idiopathic intracranial hypertension? A pilot study. This was a retrospective multicentric study. In this particular study, total number of patients which were taken, out of those, they have taken the single technique of LP. So 53 patients were not including, as they used atraumatic needle, and rest for 116 patients with suspected IIH between 2013 and 18. They were taken up. Out of that, 40 were excluded. 4 were diagnosed despite LP with CSF pressure of less than 25 centimeter of water. So these 4 patients were excluded. And 5 were diagnosed without CSF pressure measurements. 12 patients had differential diagnosis, and 2 patients were less than 18 years of old, and 17 patients had missing data. So the total 76 patients were studied, and out of 76, 2 patients were excluded because 1 needed early surgery and lost in follow-up shortly after the diagnosis. So total 74 patients were included in this study. These are the baseline characteristics of these patients. Majority of these patients were females. Average age was 30 years, and average weight was 94 kg. And most of these patients were in overweight or obese category, except for 2 patients who were in normal weight category. And previous headaches were present in 7% of the patients, and headache with migraine were present in 23% of the patients. And pregnancy was there in 4 patients, and postpartum state in 2 patients. And IIH symptoms were papilledema in 66 patients, and hemorrhage on fundus in 10 patients, and diplopia in 11 patients, and typical IIH headache in 67% of the patients. And incidental diagnosis was in 8% of the patient, and opening pressure was 36.84 in these patients. So PDPH occurred in 23 patients, that is 31% of the patient after diagnostic LP. And PDPH frequency was similar in 2 large centers, 10 patients in one center and 13 patients in other center, roughly 33% in each center. Among the 23 patients, 5 patients were treated with intravenous caffeine, and 5 patients were treated with intravenous amitriptyline, and 1 patient with gabapentin. Epidural blood patch were not used for any of these patients because of the efficacy of symptomatic treatment. But 2 patients were secondarily readmitted to hospital due to the persistent severe PDPH headache. And 1 patient had severe PDPH, and 2nd patient had PDPH complicated by SDH, required blood patch. So if we see the difference between the patients who had PDH and those patients who did not have PDPH, most of the parameters were similar in 2 groups, except for pre-existing headache, which was definitely higher in the group which he had PDPH. 43% had pre-existing headache, and 35% of the patients had pre-existing migraine. So the factors which are frequently associated with PDPH, like young age, female sex, low body mass, and frequent headaches before LP, none of these risk factors were present in this particular study, nor there was any cerebral spinal fluid opening pressure or specific IIH features which were associated with the occurrence of PDPH. PDPH, as is a chronic condition, and long-term elevated intracranial pressure could lead to impairment in central nervous system compliance. And after a while, IIH could induce raised chronic pressure regime, thus modifying the CNS compliance and increasing the pressure gradient between caudal and cranial space, which could imply that even a moderate pressure variation would be poorly these patients after LP. So this is another paper in cephalalgia, therapeutic lumbar puncture for headache in idiopathic intracranial hypertension. Minimal gain, is it worth the pain? In this prospective study, including 52 patients of IIH, showed an exacerbation in headache frequency in 64% of the patients. But in this particular study, they did not characterize whether this was orthostatic headache suggestive of PDPH or it was just the headache associated with IIH. There was another paper, cerebrospinal fluid removal for idiopathic intracranial hypertension, less cerebrospinal fluid is the. There is no specific consensus on how much CSF should be removed during diagnostic or therapeutic LPs for IIH. Clinicians often use high volume CSF removal up to 30 ml in patients suspected of having IIH, but there are little data on how much CSF volume removal affects the changes in CSF pressure. One study of the patient aged younger than 22 years suggested 1:1 linear relationship between CSF volume removed and the amount of pressure relieved when the maximum change in pressure was under 15 centimeter of water. And this particular study suggested that for every 1 ml of CSF removed, the CSF cerebral pressure decreased approximately by 1.5 centimeter of water. The previous International Headache Society guidelines published in 2004 suggested not to descend below a closing pressure of 12 centimeter of water after LP in IIH patients. Likewise, certain good practice guidelines continue to advise against excessively rapid pressure differential with the pressure measurement at the end of LP in a patient of IIH. So in this particular patients had in 80 patients, headache improved after LP and 11 patients were headache free, but headache was worse in 26% of the patients, and 8 patients required emergency visit, and 3 patients hospital admissions, and 1 patient required blood patch. And headache was same in 12 patients, and the patients lost to follow-up were 12 patients. So according to literature, the prevalence of post-dural puncture headache can reach up to 60% after LP in general population. Young women with low body mass index are more likely to present with PDPH. Use of small atraumatic needle greatly decrease the risk of PDPH. For instance, in a study, PDPH occurred after 27% of the patients versus 60% of the patients with traumatic needle. This is the atraumatic needle, and this is the conventional beveled needle which we use for lumbar puncture. The procedural factor which can be effective in reducing PDPH are use of atraumatic needle, use of small sized needle, and reinsertion of guide before needle withdrawal, and directing the bevel perpendicular to dura. So in conclusion, PDPH seems to exist in IIH patients, and clinicians should be aware of this possible event during the diagnostic assessment of IIH and should not automatically reconsider the diagnosis of IIH. PDPH prevention using an atraumatic needle and dedicated PDPH treatment may be relevant in IIH patients. With that, I thank you all.
Thank you, Jyoti, for a very nice case and quite provocative, I must say. And you have brought out, certain things from your bag. I think there will be a lot of questions on that. First of all, Dr. Reyes that ask, when do you say traumatic needle? Did you mean normal LP? Do you use Quincke's needle? What did you do in your patient?
Not Quincke's needle. This atraumatic. In my patients, we did use traumatic needle.
Traumatic needle. Oh, okay. So that is the, I think, best part of the slide. I think you showed that what should be done actually. I think we don't bother. We leave it to the residents or the junior staff to do it. But we must be kind of very much very much concerned about the effects that it might produce. And he also asked that the IIHS develops from the blockage of arachnoid granulations or narrowed venous sinuses. The raised CSF pressure is an epiphenomenon. IIH is a metabolic syndrome, leptin, etc. Your comments on that? So he considers that that is just a epiphenomenon, whereas PDPH is a iatrogenic condition. So what's your comment take on that?
And this
Hello.
Particular girl.
Hello, we can't hear you. I think your connection is unstable. Okay, can you hear me? Okay, any other members, if you of the panel, they can comment.
Sir, it's a wonderful case. I think many of us has had the experience of IIH people getting worse after lumbar puncture, and we always used to think how it happens when the pressure is more, and when you think the pressure is less, it should benefit them. But the next day they say we have a postal headache, then we stop the Diamox and things like that. So it's an interesting phenomenon. I don't know. And one of the few points is that this girl does not have any obesity. I think her BMI is within the range. So is it true BIH or IIH, or it is something else? Maybe, I don't know. Many times we see very lean people coming with papilledema, and then you don't. It's not the conventional phenotype for a BIH or IIH, and exactly we don't know whether they are really IIH or whether some mild viral meningitis early with a sequelae which is happening. So it is tough to know whether they are true IIH or they are something else.
And your venogram, was it entirely normal, Jyoti? I thought that there are certain areas which were not, quite well visible there.
So your left transverse sinus was reported as hypoplastic, but she improved after LP and she did not require any further management. She did not even turn up for follow-up perimetry.
No.
So.
Yeah. I think Thomas is right, and Dr. Ray has also raised this question that whether did you do any other markers for CVT, for example, a latent CVT, for example, protein C, protein S, and other, or you just level it as an IIH just because it was a raised pressure, because the pressure can be raised there also. I mean,
so yes, we were.
I think your connection is very unstable, Jyoti. Okay, so I think that I can summarize some of the take-home points from this. One is this, of course, that once you do the lumbar puncture in IIH, you should be careful about the technique you are employing, the needle you are employing, and of course the amount of volume you are taking out. Don't kind of take too much of volume in that, because otherwise what happens that basically when you call it as a spontaneous intracranial hypertension or even a post-dural lumbar puncture headache, we level it as a decreased pressure, but actually it is a hypovolemia which is responsible for most of the pathological process. So therefore, you have to be considerate about volume that you are taking out, and if they do develop a post lumbar puncture headache, then you have to consider that possibility that whether this is that, and then you have to actually stop the medications at least for the time being for these patients. And then, of course, there is a question from another person was asking that what happened to this patient in the follow-up. Did she require any management of IIH later? Because that will be an interesting question to answer, that what happened to her later. I think because Jyoti's connection is not so good, I think I think that she requires more assessment from my point of view, and see that how is she faring. And so I think I have covered most of the questions that are there, and I'm really slightly amused that all the three cases considered either the CSF pressure, the CVT, spontaneous intracranial hypertension, and IIH. So I would encourage the members to present some primary cases also, primary headaches, because that is also very interesting. Of course, in India we don't see a large number of secondary headaches, but I would encourage the speakers to take up primary headaches also, because they also pose a lot of challenge. Jyoti, could you hear this? Can you answer that?
Yeah. Sir, could you repeat the question? Actually, my connections are.
The question is this, that that why didn't you consider other possibilities, like did you do any other risk factors for CVT, for example, protein C, protein S, or because BMI is normal actually.
Yes, sir. So actually, I wanted to work up this girl completely. We wanted complete workup, but she was having her exams and she had a short admission. We did advise all those tests, but she said she will get all those tests done after the exam. Once the exams were
Is she coming up for follow-up?
over, she was there. She didn't even get the perimetry repeated.
Okay. Okay, that's a pity. Actually, you have worked up so nicely. Otherwise, I think, you can, ask,
She
you
didn't
must be having, the
visit
hospital must be having a number, contact
hospital,
number.
but
You can take some-
telephonically I did confirm.
Okay, right. She's
So
otherwise doing well.
one more word of caution is that this papilledema, you have to take a good opinion from a good ophthalmologist. Sometimes many ophthalmologists make a mistake with drusen or some other things they mistake as papilledema. So we have to be very careful before the lumbar puncture that's true papilledema. And maybe an optic nerve sheath diameter also little helps you
Yes.
in knowing that it's a true papilledema, because many times outside they have referred as papilledema, then our ophthalmologist will tell, no, it's a pseudo papilledema. So that also we have to keep in mind before we go ahead, especially in lean people, young lean people, not the classical obese patients with then over-the-counter medications, vitamins, vitamin D, steroids, herbal preparations, all you have to use because some of them cause raised pressure. OCP, all contraceptive pills. So we have to just make sure. Hope you have done all those things.
Right, correct, absolutely. And secondly, there is one question for you that you said caffeine. So how does caffeine?
Yes, sir.
Hello, can you hear me?
So
Hello. Hello.
She has gone again. I think her connection.
Lost. Okay, right. So I think all the three cases were very good, and actually it's a thought provoking, and they have opened up something new, and your case to a new possibility that whether CVT can precede the SIH, unlike the other cases where SIH preceded the CVT. That is one main take from you. That is a question we should all look up now in our cases. From Sanjeev's case, I think the managing the CVT in the face of ulcerative colitis, or where the patient is having an active bleeding disorder, how to take care of that. And from Jyoti's case, of course, very interesting that how should be the lumbar puncture be performed when you want to do a lumbar puncture to measure the IIH, to actually, even for it is easier said than don't measure, but for any publication, any research paper, you would like to fulfill the criteria of IIH by measuring the CSF. So a lot of people will undergo CSF measurement, and therefore we need to be careful. Yes, Jyoti, can you hear us now?
yes, sir. Now I can hear you.
Now you
I'm
tell
sorry,
me.
my connections are very
Somebody was
unstable.
asking that how does caffeine help in post lumbar puncture headache? Hello.
So
You can
exact mechanism.
Yeah.
It does though. It does. Maybe Dr. Thomas can enlighten us on this.
I don't think anybody knows how exactly the caffeine acts. It's a brain stimulant. So we are not sure how it helps in IH, but it's a general routine practice to give fluids and caffeine. So I'm not an exact molecular mechanism where which it helps in the pressure, but it's a brain stimulant. It acts through the adenosine. It's an acts through the adenosine. It's an adenosine blocker.
So I need, so all these drugs like theophylline, aminophylline, they have all been tried, with varying success rates for SIH kind of situation. But in post lumbar puncture headache, there is one other treatment which you can actually consider, and which is now found to be very effective, is the greater occipital nerve blocks. So there are at least, I'm aware of at least 2 randomized controlled trials which have shown that they are effective. So if there is an intractable post lumbar puncture headache, you can consider genital occipital nerve blocks. We have experience of 2 patients, and both of them actually fared very well after the occipital block. So I think,
yeah, post lumbar puncture headache, hydrocortisone 50 milligram 8th hourly may help. Very small course of this thing, but in a raised ICT it will be difficult, and you have to be careful.
Yeah, so I think there are 2 more questions have come up. Follow up, obviously this question has been answered that you didn't have this thing. Yes, caffeine adenosine pathway, you are right. And obviously Dr. Ray has given a, kind of a reference to the lumbar puncture needle size. It's time to change the needle, lumbar puncture. So I think all of you can actually go through this, which is a free article. Thank you, Dr. Ray, for sharing this with us. Thank you very much.
Jyoti, you also told some IV amitriptyline? IV amitriptyline? Unmute.
Yes, sir. That was reported in that particular paper. Even I was amused to find IV amitriptyline. I have not used it.
I think it will be dangerous because some cardiac problem.
Yes, but it was reported in that particular paper.
Right. So I think that let's leave out the audits. Let's concentrate more, which we can do and which is usual, and to help our patients. So that is very important. So I think we had a very engaging session for 1.5 hours, and I think from next we would try to do something more so that we have a full 2 hours meeting, and I would require and request your suggestions for the same. And I think that we can actually go on, and if it is successful, then we can make it a monthly event after about 3-4 such sessions. You kindly give your inputs for this program, and there are more to come. And I thank all the 3 speakers and our president, Dr. Nirmal Surya, who was kind enough to join us, and of course Dr. Ashish Duggal, who has been instrumental sending mails and all. Thank you, Ashish, for being there, and I hope that we will continue with this kind of meeting in future. So thank you very much.
Thank you, sir.
Namaskar.
Thank you, Devasis, sir. Thank you, everybody.
Thank you, sir.
Thank you, Nirmal sir.